Hello everyone, I'm Dr. Bozorgi, cardiac electrophysiologist, and very welcome to ECG Refresher. Today, we'll discuss a young female who presents to emergency room with 3 hours of chest pain and this ECG. Before we dive in, I want you to pause the video and take a moment to focus on ECG. I'll provide a true explanation shortly thereafter. As you can see here, the ECG shows a normal sinus rhythm with a heart rate about 100 beats per minute. But what caught our attention are the ST elevation observed in several leads, including 1, 2, 3, AVF, and approximately all chest leads. Whenever we encounter ST elevations, the first condition that comes to mind is myocardial infarction, but it's essential not to overlook other possibilities. Let's go through some potential causes of ST elevation on ECG. Ischemic heart disease, including myocardial infarction, Prinzmetal angina, and ventricular aneurysm. Pericarditis, which we'll be focusing on in this case. Left bundle branch block, characterized by ST elevations in V1 to V3, and benign early repolarization. This is a normal variant with J-point elevations. Now, let's zoom in to our case. There are features that point toward pericarditis in this case. The ST elevation are diffuse across multiple leads except AVR, which is opposite to other leads, and have concave shape. Concave. This pattern differs from myocardial infarction, where the ST elevation tend to be localized and often accompanied by reciprocal acid depressions and Q wave formations, and it is convex in case of myocardial infarction. If I want to make a mnemonic for MI and pericarditis, I can use a sad emoji for myocardial infarction and a happy emoji for pericarditis, since pericarditis usually has a better outcome. There is a notable displacement of PR segment suggesting subepicardial atrial injury. We observed PR depression in lead 2 and PR elevation in lead AVR. Sinus tachycardia is also present, which is common in acute pericarditis due to pain or pericardial effusion. These features collectively point to pericarditis, but we can also use other signs for differentiation. One such a sign is spodic sign, which is down-sloping TP segment seen as an early ECG manifestation in about 30% of patients with pericarditis, best visualized in lead 2 and, of course, lateral precordial leads. Our case had passed early stage and other ECG findings are more prominent. Pericarditis can be difficult to differentiate from benign early repolarization, as both conditions are associated with concave ST elevation. One useful trick to distinguish between these two entities is to look at the ST segment T-wave ratio and also fish hook pattern. To measure this ratio, the vertical height of ST segment elevation from the end of the PR segment to the J point is measured and compared to amplitude of T wave in V6. A ratio of more than 0.25 suggests pericarditis and less than 0.25 suggests benign early repolarization. Let's go for an example. Here, ST segment height is 1 mm, T wave height is 6 mm. So the ratio is 0.16, obviously less than 0.25, so it's consistent with benign early repolarization. Here, In this example, ST segment height is about 2 mm, T wave height is 4 mm. Ratio is now 0.5, so it's pericarditis. Easy peasy. And let's look at fish hook sign, fish hook pattern. It is another clue that suggests benign early repolarization. This notch and irregular J-point called fish hook pattern. This is often best seen in lead V4. And there you have it, a detailed exploration of the ECG finding associated with pericarditis. Remember, ECG interpretation requires attention to detail and considering all possible diagnoses. I hope you find this case as interesting as we did. Stay tuned for more educational content and insights in our upcoming videos. Thank you for watching and see you next time.